Yeah, we can hear you.
All right, so thank you very much. This session here is the UZIMA session, and we have 3 speakers this session, round 1 of the networking. So we are going to have, because there's so many people, we cannot introduce everyone, but I'd like to introduce myself. My name is Marian Kosa-Thomas. I'm a pediatrician and public health expert, and I'm one of the program scientists for the UZIMA project. I'm here at the Eunice Kennedy Shriver Institute for National Institute for Child Health and Development. And it gives me very great pleasure to welcome you all. And if you don't mind, because we do not have enough time to introduce everyone, just feel free to put in the chat where you're coming from, your name, and let's just have an idea of who's in the room. So while you're introducing yourselves in the chat, I will go ahead and invite and make sure I have my first speaker here. Dr. Amina Bubakar. Amina, are you on the line?
Yes, I'm on the line. I hope my internet doesn't play up. Thank you.
Hi, and I believe you do have slides that you're sharing in person, correct?
Yes, I have
All right.
slides I will share.
Awesome. All right. So as we see the names coming through, we're welcoming everyone in. Good to see the broad engagement. And Amina, over to you.
Thank you, everyone. Just give me a few moments. I set up the slides. Yeah. So thanks, everyone, for your interest in UZIMA. My role here would largely be to introduce the hub and just to give a little bit of snapshots of some of the work we've been able to achieve. And then my 2 colleagues would go into greater details about the pilot work. So really the role, what we aim to do in UZIMA is really to set up a scalable and sustainable platform that can use artificial intelligence or other machine learning-based methods to develop predictive models that can be used as forms of early warning. And we have 2 critical areas of interest. That's maternal, newborn, and child health and mental health. So really where we saw as critical gaps we can fill include harmonizing of different data sources. For instance, we have data from households being able to harmonize with data from hospitals and community level data, but also being able to leverage on longitudinal data sets since our work is based on within demographic health surveillance, some people are being tracked and being able to look at what has happened over a long term. But more important, because predictive models are not so useful if they're not used, we really wanted to come up with ways of ensuring we can engage key stakeholders to identify ways in which we can disseminate these models and get them implemented within targeted communities. So the UZIMA Hub has 5 cores. The first one is the admin core, which runs the day-to-day things within UZIMA. We have the data management and analysis core, which has really helped us to set up the infrastructure for UZIMA and the data analytic approaches. And then we have the dissemination and sustainability core, which really focuses on how best can we move around ensuring that the info we get from the research reaches those who can either implement it in policy or in practice. And within UZIMA, we have 2 research projects, the maternal, newborn, and child health, and the mental health projects. So within mental health, there are 3 key projects. One is around looking at ways in which we can use mobile signatures for depression and anxiety, really to be able to understand the mental health of healthcare workers in Kenya. The second project looks at ways in which we can follow up children. We had data for these children when they were very young, 0 to 5. Now they are young adults and adolescents. Yeah? Looking at collecting data and looking at what were the predictors very early on of potential for depression and suicide ideation. And lastly, to set up a longitudinal study among the university students to understand really risk factors and ways to support them in terms of their mental health. And I won't go through each of these bits of work, but they've all started. I can just mention, for instance, the healthcare worker project. We've been able, the first thing since really using Fitbits to collect data longitudinally was quite of a novel idea in our setting. We did a pilot study. We included 50 healthcare workers and looked at feasibility, acceptability, some of the challenges, and we were able to use this pilot data to refine the study and the study methodology, largely because not only did we administer this pilot data, but we had a series of qualitative interviews with those who had participated, and they gave us their experiences. From there, we recruited 527 healthcare workers who are being followed longitudinally for at least 6 to 12 months, and the study would end in November 2024. Yeah? So based on this, really, we've been able to learn a lot about the potential use of digital indicators and wearable technologies in terms of tracking mental health. The maternal, newborn, and child health section aimed to look at how can we develop predictive models of poor pregnancy outcomes, models of risk of non-communicable diseases for those people who had maybe, let's say, high blood pressure or diabetes during pregnancy, but also really be able to look at predictors of long-term health and functional outcomes. Again, within these projects, we have 4 or 5 different sub-projects going on. An example of that sub-project is one whereby we have set up a study where we'll follow children between 0 to 6, not from birth until 36 months, and we collect a series of data from their developmental outcome, household factors such as food insecurity. We look at the home environment. We collect nutritional data using anthropometry, but we are also looking at geolocation data, like access to health facilities, educational facilities, to markets, which would represent access to fresh foods. And a PhD student, we've already done 3 rounds involving 2,000 mothers and children over the last 1.5 years, and we'll continue collecting this data. And you can see that our PhD student has already started looking at some of this data, and she's been able to, for instance, rank which are the highest risk factors in terms of poor childhood outcomes, and the home environment comes very strongly. Now, this is interesting because most of the factors that we are able to identify within the home environment are modifiable. Actually, quite a large number of these factors are quite modifiable and are things that would really be able to advise the kind of interventions we are able to develop. And what we are keen is that based on this kind of results from the longitudinal work, be able to develop a risk index for children and mothers and really indicate which are the best points for intervention. We've done quite a lot in terms of the dissemination and sustainability core. Some of the work we have done includes developing and implementing an advanced data journalism training program, providing the journalists with seed funding for them to be able to report on mental health and to report on maternal, newborn, and child health. What's unique about this is that we're really focusing on ensuring journalists can look at scientific data, try to interpret it, and report it in the most accurate manner possible, but also make stories that are very much of interest to, people would find it interesting and want to engage with those stories in terms of solutions for these areas of interest for us. We have carried out health communication and policy engagement training for our scientists, largely because in quite a number of settings, scientists might be very good in terms of talking to fellow scientists. But this really was targeted at, helping people with their skills on developing podcasts, talking to people who are not scientists and simplifying your language for better communication. So we find that quite a lot of work has gone, and I think I won't go into the exact details of all the participants, but yeah. a lot of stories based on these trainings are now coming out into our daily newspapers and other feature places about the work being done, not just by UZIMA, but also in terms of talking more and featuring mental health issues and maternal, newborn, and child health in really increasing its scope. The last core within UZIMA is the data management and analysis core. And this core really has supported in terms of first ensuring data is acquired and put on a cloud system, and developing protocols for ensuring compliance with the Kenya data protection laws, ensuring good practice in terms of how we handle data, but also providing support in terms of training in artificial intelligence, machine learning methodologies. So we have quite a number of our fellows who are getting trained, getting mentored in terms of using these models and doing the prediction. And with that, I think I'll end the introduction for UZIMA there. And feel free to visit our website where there's, quite a lot of updates regularly about the work we are doing. Thank you.
Thank you so much, Amina. So she really made it sound so simple and simplified, but I've actually visited the site, so I know the incredible amount of work that's happening down in Kilifi. So I'm just gonna open up the chat to any questions that people may have. Please feel free to raise your hand, and then we'll give Amina a chance to respond. Okay, so going with Hill, I'm gonna pronounce your name wrong. Yes, you go first.
Thank you, Amina, for your great talk. I'm interested in your cohort for NCD development. What proportion of that is HIV positive? We are actually, I actually should say we're one of the new U01s. We are predicting NCD development using longitudinal retrospective data. So I think it might be interesting to see if we could have some kind of collaboration for validation in terms of your findings. So what proportion of your cohort is HIV positive? So we basically have children from Uganda and Botswana for our study. Thank you.
Thank you. So I would need to look at the data. I know at pregnancy they were all tested, but I don't have the stats here. So I would say let's get in touch and we can look at that data. It's available.
All right, next we have Jalili Oyelade.
Thank you for that wonderful presentation. Yes, I'm really excited. Actually, my question is the area of the machine learning that you want to use for the prediction of your projects. So you did not state exactly the specific, we have various types, categories, or methods of machine learning. So which of the approach are you going to use in your machine learning, for your prediction? Thank you.
Okay, thank you. So I'm going to attempt to answer this, but I'm not the expert in machine learning. And Dorcas, you're here, so please feel free to jump in and contribute. My understanding is that various studies may use different methods. In fact, one of our fellows, James Orwa, has actually tested the different methodologies on one data set to see which has the best prediction. So I don't think we aim to use only one across all the different data sets. I think the one that provides the best fit and the best model is what is likely to be used for that data set. And Dorcas, please unmute and contribute.
Thank you. Okay.
Yeah, hello. Yeah, thank you for that, Prof. And what Professor Amina has said is true. So there's no one machine learning algorithm that will be considered for all studies. So it will be on a case-by-case study where we'll be evaluating the different machine learning algorithms and evaluate how best they perform in the different data sets.
Okay.
So
Thank you.
yeah, so it seems like Henrika, was that your question as well? It says what tools/software was used for the cloud data and for building the models. So I'm guessing that was along those lines as well that you had
So the
in the
cloud,
chat. Go ahead. Enrique.
It's Azure, I think, on Microsoft. Again, Dorcas confirmed that. I'm more of the content expert, so I'm learning
Okay.
as I go, but it's Azure on Microsoft.
Okay.
Dorcas?
Yes,
All
for
right.
the cloud platform, you're employing use of Azure.
Enrique, was that your question? Okay,
Yep, thank you.
perfect. All right, one last one from Oscar Nyangiri, and then we will have the pre-recorded. So actually, Dorcas is one of our speakers. Are you actually planning on giving a live presentation?
I had recorded one, but I can give a live also if needed.
Oh, perfect. Okay. All right. I'm hoping the IT people won't mind us doing that, but Oscar, go ahead with your question.
Thank you very much. I'm seeing you're doing very great work. Some time ago, I saw that some people actually are able to apply and get some grants to leverage your platform to give a solution. So I'm just wondering, how does it work? Is it something you're going to share with us? Do you have such challenges where you have some sub grants to collaborate and work together and develop a solution? Thank you.
Thank you, Oscar. I think for the last 2 years, we've been having pilot projects. In fact, the 2 that will be presented are part of the pilot projects. And we did send out calls and people applied. I don't think we'll run new pilot projects at the moment, but we are always open when other people have ideas that can leverage on the infrastructure that we have invested in for people to approach us to discuss and agree on it.
Yeah, thank you very much.
All right, and just one last note that James was kind enough to put in the chat a bit more information about the algorithms that they're using in UZIMA. So just so we don't lose time, can we, if you're not, some hands are still raised, but I think they were from prior questions. Can we then move? Dorcas, are you staged to have your slides done live now, or you still want us to play the pre-recording? Amina, thank you so much. Don't go away though, because we may have more questions at the
I'm
end.
here.
All right, Dorcas, are you able to do that? Because we do have one more presentation after you, and we're short on time. We only have 15 minutes for this session.
Okay, thank you. So let me just share my slides then.
Awesome, thank you very much. Thanks. Okay.
Okay.
Whenever you're ready, let's go.
It will take a minute for me to open. So thank you for the chance. My name is Dorcas Mukireri. I'm a research fellow at Aga Khan University and the Population Health Department attached to the UZIMA-DS project. And I'll be presenting on our...
Sorry, Dorcas, we don't see your slides. Are you present?
Oh, just a minute.
Or else I can play your recorded for you.
Yeah, kindly. It's okay.
Which one do you prefer?
I think she said to go ahead and play it. I don't know that it's because we can't see your presentation, Dorcas.
Okay, just, yeah, you can proceed to play.
And since you're here, we'll just, have all questions in the chat. And there we go. Thanks, Wisdom.
Hello, my name is Dorcas Muyerezi, a research fellow at Aga Khan University under the UZIMA-DS project. And today I'll be presenting our pilot project on antenatal risk stratification for prediction of gestational diabetes mellitus during the first and second trimester using machine learning models. The project team is composed of individuals both from Aga Khan University in Nairobi and Karachi in Pakistan. So I, as the PI, Professor Anthony as the co-PI, who is an epidemiologist, Dr. Rumi Chunara, who is a data science expert, Dr. Rumi Nurdin Mohammed, who is a GDM expert, Amos Bunde, who is a data architecture expert, and Angela Koech, who is a GDM expert. For this study, we have the three objectives listed here. That is, one, to summarize the GDM risk factors during the first and second trimester of pregnancy. And this will be particularly for the Kenyan context, as the data we'll be using will be data retrieved from Aga Khan University hospital facilities in Kenya. The second objective is to develop a robust machine learning algorithm for early prediction of GDM in the Kenyan setting. Then we'll go ahead and validate the performance of the developed machine learning models for early prediction of GDM. If I'm to take you through the background and significance of our work, it is estimated annually that 2 to 10% of pregnant women worldwide are affected with GDM. When you narrow down specifically to Africa, the average prevalence is recorded at 13.6, and this is seen to be slightly higher in the sub-Saharan region. GDM has largely been associated with long-term and short-term health conditions for both the child and the mother. Thus, critical prenatal phases require careful monitoring and management to mitigate some of the risks. In terms of cardiovascular implications, specifically to the fetus, it has been seen that a fetus that is exposed to poorly controlled GDM tends to experience subtle yet silent cardiovascular dysfunction. In terms of neurodevelopment disorders, it has been seen that GDM has led to an increased risk of neurodevelopment disorders that include the autism spectrum disorder and ADHD, particularly to the fetus. Thus, it is important to understand this association, and by understanding this association of the different risk factors, then there is need of early diagnosis and interventions strategy to support the affected children and help the mother also to overcome some of the challenges that come as a result of the GDM. Some of the effects of GDM on women include prolonged labor, development of type 2 diabetes, and operative delivery and preeclampsia. Specifically on the infants, it may lead to risk of microsomia and preterm delivery. Traditionally, diagnosis of GDM is made through the single-step 75 grams oral glucose tolerance test, commonly known as the OGTT test, which is specifically done between 24 and 28 weeks. To avert some of the issues that arise as a result of GDM, then it becomes crucial to diagnose the GDM early enough before the 24 weeks to 28 weeks where the OGTT tests are often conducted. With the development in technology, we have massive data collected under the EHR, that is the electronic health record. So availability of this secondary data makes it more viable to adopt use of statistical and machine learning models to predict the occurrence of GDM. Research has been done and machine learning algorithms have been seen to outperform statistical techniques in terms given a complex data, because machine learning algorithms have been seen to largely leverage on the relationships that exist within the data without prior specification of the underlying models. Authors in the paper I have just listed there suggested adoption of machine learning for early prediction of GDM. So there is works that exist on use of machine learning model for GDM prediction, but on literature, it has been seen that these tasks or these studies have mostly been done in China, very few existing in the low middle income countries, other low middle income countries, and no studies are available for data that has specifically been collected in the Kenyan context. So this work, we intend to develop our machine learning model to predict GDM early enough in the Kenyan context using data obtained in all AKU facilities around Kenya, that is in Nairobi, in Kisumu, in Mombasa. How is our work relevant to the UZIMA-DS hub? So this work extends into the antenatal period. It extends to the antenatal period, the UZIMA-DS study, to predict postnatal and long-term outcomes of perinatal insults. It contributes to the preliminary work with EHR datasets for potential UZIMA phase 2 UZIMA-DS funding. And then it also fosters intra-AKU collaboration between AKU East Africa and AKU Pakistan. This study will adopt a prediction modeling approach using AI and machine learning approach. The subjects who will be eligible in this study are subjects who are registered in the Aga Khan University Hospital. Participants who have type 1 and type 2 will be excluded for this study. And then for ethics and approval, and privacy, the Aga Khan University Institutional Scientific and Review Committee and NACOSTI will be sought for approval for this study to be conducted. Some of the data, a description of the data that we're going to use for this work is as listed here, where we have the different categories and the variables that exist within the categories. So for example, for the patient demographics, we're going to obtain data on the sex, the date of birth, the address, the BMI that will include pregnancy, the BMI during the first trimester, and then the BMI during the third trimester. We'll also obtain data about the patient's medical history, such as previous history of diabetes, previous history of high blood pressure in pregnancy, history of GDM, family history of diabetes mellitus, then the mean arterial blood pressure in the first trimester and the PCOS. So this is a definition of the different variables per category we're going to obtain. If you see in terms of the location details, we will obtain data from Mombasa, from Kisumu, and from Nairobi with an aim of testing the geographic differences to identify if the prevalence differs between the different locations as listed here. We'll also get to retrieve the laboratory and diagnosis tests in addition to the medical information associated with that specific patient. For data analysis, we'll begin with data extraction. We have so far developed the architecture for moving our data from the AKU EHR to the UZIMA-DS cloud platform, where data pipelines will be created to move the data from the EHR to the cloud platform, as shown here. And the inner cloud platform is where we will now do the analysis. In terms of the data preprocessing, variables with more than 40% missing or more missing values will be excluded, and imputation will be applied only if the missing data is less than 40%. To test and train our model, we will split the dataset using percentage split of 70%, where 70% of the data will be used to train the machine learning model, while 30% will be used to test and validate the outputs of the model. The models that we're going to use has largely been informed by literature. Our selection of the models were as a result of models that were seen to perform better in literature, and those include logistic regression, support vector machine, decision trees, deep neural network, KNN, and then ensemble models such as the gradient boosting, adaptive boosting, light gradient boosting, random forest, and the extreme gradient boosting. A comparison of all these algorithms will be made to identify the algorithm that best performs given the data that has been obtained within the AKU facilities. To evaluate these models, performance metrics such as the accuracy, the precision, and F1 scores will be used in our context. We have so far managed to extract the data, metadata, to give a description of the different variables, the unit of measurement, and description of each variable. For instance, within the table, in the database, we have the ICD pin, which is recorded as a string, and it identifies the patient. It's used as the patient identification. We have ICD age that is recorded as date time, and it records the patient's age as of the time of diagnosis. We have got the year of birth. So this table actually gives a description of the metadata, the variables being variable name indicating the variables that are of interest to our study. So if it's about the gender, we only have 3 categories that have been recorded in the database that include the male, female, and other. Some other variables as have been listed are as listed here, where we are going to be obtaining this data and trying to associate them with the main aim of identifying the risk factors and later feeding it to our machine learning model to predict the GDM early enough. So, for instance, in terms of examination variable, this is recorded as a string value, and it's actually the examination that was done either through scans or blood tests. The findings will be as defined using string or text values, and the description is the doctor's finding after the procedures had been conducted. So what do we expect from this research? Number one, we will develop and validate algorithms that allow early identification of GDM, and these will enable timely interventions and ultimately improved maternal and fetal outcomes. Number two, the insights and knowledge we'll generate from this study will contribute to the novel GDM risk factors and identification of further preventive research questions. So those are some of the outcomes that we intend to get to this study. So these are some of the references for our work. Thank you.
Thank you so much, Dorcas. I was trying to encourage people to put any questions they had in the chat ahead of when the session or the presentation finished in order to make sure we have everything covered, but I don't see anything yet. So if there are any questions, please raise your hand. And if not, we will then have the final presentation and then open the floor for additional questions. So we do have the benefit of having Dorcas here. So any questions, please let us know before we move on to Nandi Miso's presentation. And it seems like you did touch on some of the questions that came up earlier in the main, after Amina's question with regards to the exact modeling going on. All right, so we have Ida Obowe. Ida, please go ahead.
Okay, thank you very much, Dorcas, for the presentation. Now, I was just wondering, because you had quite a number of variables that you are using for your predictions. Was there a way of finding out whether all the variables are significant for the study? Or do you use all the variables that you measured? Thank you.
Okay, thank you for that question. So we're currently in the process of running experiments to look at the prevalence. First of all, I think it is from that way we'll be running some bit of logistic regression to try to see some of the variables that are relevant. And the results we get from that experiment is what will inform the machine learning experiment. So that for the prevalence and the to identify the risk factors is our first objective. Then the results we get from running these experiments will then inform the second step, which is the machine learning algorithms. So definitely we'll not be using all variables for the machine learning specifically.
And I suspect, Anthony, you're going to chime in and add to that. I'll do that before I go to Jalili. Jalili, I'm sorry, I know because
Thank you.
Anthony is very closely involved in this.
It's actually just typing, just in case you didn't see my hand. So there's an embedded process of mapping the variables to the aims of the study using human in the loop, using working with the content experts who are experts in GDM, obstetrics and gynecologists. Yeah? So that is inbuilt into the study as well, that we make sure that we included the models, the variables and data parameters that are relevant from a biological perspective or from a pathophysiologic perspective as well.
Yeah, and I see that James also endorsed that in the comments in the chat. And yes, I've been on some of these calls and they've done several iterations because exactly Dorcas said, there's sometimes the data is just not there. It's a lot of missing data. So you have to like kind of weed out the parts that you don't, you're not able to use. Otherwise it messes up your algorithm design. So I do have, please check the time. All right, we will. So Jalili, just very quickly, and then we have to have the last presentation so we don't have that person miss out. Jalili, go ahead.
Okay, thank you. And that's a wonderful presentation. I have just two very brief questions. So the first one is why presenting, though I start to be corrected, I don't know if I get that aspect very well, where the extent study in the areas, so focus more, concentrate more in China. So, and that motivates their study because, so nothing, he said that nothing has been done yet in Kenya. I don't know, is it as a result of lack of data sets that constitutes to that or not? So that is question number one. The second one is not a question per se anyway. So it has to do with the method now. So they say they're going to use AI stroke machine learning. I think AI and machine learning. So when we say AI is a superset, is generic. Machine learning is a subset of artificial intelligence. So, and from what they demonstrated, so the method they intend to implement is
So I'm having a little bit of a problem.
stick to
Oh.
that. Yeah.
Okay, it's cutting out a little bit, and I know we're.
I think that's my contribution in that.
Okay, I think I captured it. What I'll do, let us have this, let's start since it is a pre-recorded presentation for Nondamiso. And then I'll try and catch that. Plus there's a sample size question in the chat as well. And then we'll try and make sure we address those before the end of our breakout. So if Wisdom doesn't mind, could you go ahead and start? Nondamiso, did you have anything to say before we started your presentation recording?
No, you can go ahead and play the
Okay.
recording.
All right. Thank you so much. And thank you, Dorcas, for an excellent presentation. And last but not least, we have our second pilot, which is part of the UZIMA project. And we'll get to hear about Nondamiso's work that she's been doing.
Hi, everyone. My name is Nondamiso Mtiane. I'm from Africa Health Research Institute. I'm leading one of the UZIMA pilot projects titled Establishing a Fair Data Resource for Adolescent Mental Health Research in Africa. So this pilot project focuses on data harmonization. Before I discuss the project, I'll provide some background. So there's high levels of mental disorders such as depression and anxiety among adolescents, and these mental disorders are the main causes of illness and disability among adolescents. In sub-Saharan Africa, they are driven by multiple factors such as poverty, unemployment, HIV, and exposure to different forms of violence. Most mental disorders are not diagnosed or treated due to a lack of mental health resources, including locally validated screening tools. So there's a need for evidence-based interventions to prevent and treat mental health problems. But before we talk about evidence-based interventions, we need data to be able to understand how social factors and individual level factors interact to predict the risk of mental health problems among young people. So the aim of this study is to create an open access data resource that will be accessible to other mental health researchers in Africa. And the secondary aim is to investigate the socio-demographic, clinical, psychological determinants of poor mental health among adolescents. This study is conducted at Africa Health Research Institute, known as ARI. So ARI is located in KwaZulu-Natal, which is one of the provinces in South Africa. The map on the right-hand side shows the ARI Health and Demographic Surveillance System, which covers a population of about 200,000 people. So ARI has got two campuses. There is Durban campus, which focuses on translational science, and there's Somkhele campus, which is like a rural campus, and it focuses on population science and implementation science. So most of our studies are conducted at Somkhele campus. So from ARI, we identified 5 studies that collected data on mental health among adolescents. So the first study is DREAMS. It evaluated the impact of combination HIV prevention on new HIV infections among adolescent girls and young women aged 13 to 24. So the study was an observational cohort study, and it was conducted from 2017 up until 2019. And then the second study is multi-level study. It evaluated the same interventions as DREAMS, and it recruited adolescent boys and young men aged 13 to 35 and young women aged 24 to 29. And this study was implemented from 2018 up until 2019. And then there's Isisekelo Sempilo, which is a randomized controlled trial. It evaluated the impact of exposure to sexual reproductive health services and peer support on transmissible HIV. The study was conducted among young people aged 15 to 30, and which were recruited from 2020 and were followed up until 2022. And then there's another study, which is Tetanami. It's a randomized controlled trial. It evaluated the impact of biosocial intervention on HIV infections and transmissible HIV among young people aged 15 to 30. The study was implemented in 2022 and is still ongoing. And the last study is treatment as prevention trial. It's a randomized controlled trial. It evaluated the impact of universal test and treat on new HIV infections among individuals aged 15 or above. So from these studies, we are only interested in adolescents and young adults aged 10 to 24. So here I'm just describing the methods that we used in our pilot study. So we collected metadata, which includes study protocols, data dictionaries, and study questionnaires. And then from these materials, we then identified the variables that we need for our pilot project. And then we created a list of target core variables. And then after that, we performed data harmonization, which involves combining different variables and transforming them into one format. And then after data harmonization, we then perform quality control, which involves comparing raw data with harmonized data to see if there are any issues. So if we identify any issues in the data, we then repeat the data harmonization process until all issues are resolved. And then after that, we will then upload the harmonized data, including the raw data, on the repository. So on this slide, I'm just showing how the final data will look. So on the last column is just the harmonized, shows the harmonized variables. So we will have, for example, for depression, we will have a depression outcome, which is a binary variable, which indicates whether a person has depression or not. And then there is also depression score, which is calculated from PHQ-9 items. And then each variable will be linked to an individual. And since this is a longitudinal data, we'll also have a time value, which indicates the year in which the data was collected. And the harmonized data will then be linked to raw data. So for that harmonization process, we combined different variables from different sources and transform them into a common format using Julia programming language. And then we stored the harmonized data in Microsoft SQL Server database. So here I'm just showing the list of variables that are contained in the harmonized data. So we included 3 outcomes. So the first outcome is depression, which was measured from PHQ-9, and we used a cutoff of 10. And then this Shona symptom questionnaire, which measured combination of depression and anxiety symptoms, and the cutoff that was used is 8. And then there's also suicidal ideation, which is derived from PHQ-9 and SSQ-14. We also included exposure variables, and these include social demographic, food insecurity, social support. We also have data on orphanhood, migration history, and also on behavior. We also included clinic data like STIs and reasons for visiting clinic. And thank you so much for